Now in the new year, I thought we'll have a focus for the department, focus for all of you. And if you take that as a motto, the motto or your resolution should be safety in anesthesia, not just for this year, from this year onwards. That is what is my intention of taking this particular lecture on this particular day, though whatever was scheduled before was something different. I just want to draw your attention to this. I invent nothing, I rediscover. That is what is the words spoken by the Auguste Rodin. Anybody know who is this Auguste Rodin? French sculptor. Yeah, who did things out of the way, and he said, I am not inventing, but I am only rediscovering whatever is already there. The same thing is the motto here also. If you just go back, William Thomas Green Morton on 16th of October 1846 demonstrated that ether can be used as an anesthetic. Okay, and this is the inscription that was put on his dome after his death. Fine, in 1847, November, the chloroform was identified as an anesthetic and then introduced into clinical practice by James Simpson. On 28th of January 1848, Hannah Greener, 15 years old, came for toenail removal under chloroform anesthesia and she died. First death under anesthesia was recorded at that particular time. So, who is to be blamed? Is it the drug? Is it the equipment, technique, knowledge, skill, or attitude? What is to be blamed? That's precisely what you'll have to reflect on. All truths are easy to understand once they are discovered, and the point is to discover them. That is what is told by Galileo Galilei, way back, long back. Now, 100 years after discovery, 1846 and 1946, 1950s, what do you find? Still safety was equated to escape from death. That is what it is. And if you look at the paper that have been published in 1946, 48 and all that, all of them address the death under anesthesia. Death on the operating table, death under anesthetics, dangers of modern anesthesia and demands to improve the status. All this was the status in 1950s. If you look at the first editorial, first issue of Anesthesiology, Volume 1, Number 1 in 1940, the then editor and director of laboratory, that's Howard Haggard, he wrote saying that it is not enough that good anesthesia can be given and that it is given to a fortunate few. What is real importance is that all anesthesia shall be the best that modern knowledge affords. Even after 75 years, the statement holds good. Understand, the statement still holds good. It is not enough if you give it to a fortunate few. It should be to all the people what the modern anesthesia can offer. That is what happened in the next 25 years, 50 to 75. The introduction of drugs like muscle relaxants in the 50s, potential inhalational agents in the late 50s, short-acting narcotics in the early 70s, IV induction agents mid-60s and 70s. All this happened at that time. And continuing with that, in the equipment side, designing of the precision vaporizers took place in the early 60s. Understanding of the positive pressure ventilation happened in mid-50s. And understanding of the importance of airway maintenance and endotracheal anesthesia was established in 70s, and better cardiovascular monitoring and interpretation of the findings also in the mid-70s. Now, this led to transformation of the art of anesthesia into science of anesthesia. And that is the time I entered into the field of anesthesia, mid-70s. And this is when there is a transformation from art of anesthesia into science of anesthesia. All of you are learning the science of anesthesia and not the art of anesthesia, which is also important. Now, in the last quarter, between 1975 and 2000, what happened is there was a focus on safety of anesthesia. There was research into long-term safety of drugs before clinical use. For an example, I put this isoflurane. Isoflurane was identified in 1962 to be having an anesthetic potency. And it did not come into clinical practice for the next 20 years because it was told that this is carcinogenic and should not be used. So they have to re-establish with all clinical trials for the next 20 years to show that it is not carcinogenic. Then only it came into clinical practice, that's in 1982. So 20 years is spent on establishing the safety of the drug before it can be used in anesthesia. But if you look at the earlier days between 1925 and 50, each and every drug that you look at which has some kind of a relationship to the ether was tried as an anesthetic without any concern for what are the long-term effects. And so many drugs have been tried at that particular time to identify whether they have the anesthetic potency, and also used on human beings. Whereas this here, you will have to go through animal trials for 20 years to establish that there is no carcinogenicity before it can come into clinical practice. Then we had a thorough understanding of the pharmacokinetics and pharmacodynamics of the drugs that we use, and precise delivery of the drugs to meet the surgical demands with early recovery. We had all the infusion pumps and this and that, all that came into being in that last quarter. And redefining of anesthesia gas delivery system to prevent delivery of hypoxic gas mixtures also happened during this quarter. Okay, all this happened in this last quarter of the century. If you look at the administration of anesthesia, it is functioning as a system. Each and everything is functioning as a system. Even if you take your e-portfolio, it is functioning as a system. Do you understand that? Any system should have a structure and should have a process, the way the structure is used, and the way the structure and process are combined gives you an output. If the structure and the process are not satisfactory, then the output is not satisfactory. Understand? So the same way, anything you take, a department you take, you have a structure in the department, there is a process which you'll have to follow, and that gives you an output. So similarly, the functioning of a system, anesthesia also functions as a system. And you have a structure, and the process, the way the structure is used, and outcome, the structure-process interaction. That is what it is. And what it is? Structure of the system, you have the anesthesiologist, you have the surgeon, you have the theater personnel, you have the patient, you have the administrators, and you have the machines. All of them form part of the structure. And the interaction between all of them is a very complex interaction. If a theater boy is not satisfactorily functioning, your output is going to be affected. If a theater is not supplying what is needed, administrators don't give you what you need, then your functioning is going to be affected. So the structure affects the process, and the structure-process interaction leads to the outcome, and we want a satisfactory outcome. Now, if you look at the process, there could be a lot of mishaps during the process, that is errors of commission and errors of omission. These two, administration of wrong drug, wrong label, here forgetting to switch on a ventilator when the patient is connected. So all this goes in the process. Few examples of that. And human factors have a large role to play in the process, all of you. And what does that interfere with the human factors? These are the factors. One is hurry in starting a case, or hurry in leaving a case and going somewhere, aging, lack of sleep, inattentiveness, carelessness, and incompetence. These are the factors, human factors, that play a major role in the process of administration of anesthesia. Now, on the equipment side, again here on the drugs you have the same thing, wrong labels, similar ampules, similar labels. On the equipment side, there is a lack of standardization, defective equipment, lack of proper maintenance, and lack of monitoring. These are on the side of equipments. So if you just go back and Google, put that words deep sleep, 6,000 will die or suffer brain damage. If you just put that as a search word and put it, you will get this page. What is, if you read that page, what does that page say? Thursday, April 22nd, 1982. ABC Television, a segment of the program 2020. And we have just entered into 2020 now. Okay. Yeah? And what did it say? If you are going to go through into anesthesia, you are going on a long trip. And you should not do it if you can avoid it in any way. That's what they said. And this year, 6,000 patients will die or suffer brain damage. That is the opening statement of that particular program. And then there were a few video clips that were playing, and then they showed a few people who were there and people who were affected because of wrong administration of anesthesia. And then they said, the people you have just seen are the tragic victims of a danger that they never knew existed. That is how the program went. It's a program for 20 minutes. Okay. And so the program never existed. And what is that danger? Mistakes in administration of anesthesia. That is a danger that never knew that can lead on to so much catastrophe. Now, in the concluding remarks, they said there is a hospital in New York City where there are 2 anesthesia people covering 5 operation theaters. Is the situation any different now here in our hospital? No, I have to see. Okay. How do they do it? Well, they run quickly and pray a lot. So, in your emergencies, I suppose that's what you are doing. This led on to formation of Patient Safety Foundation by Ellison Pierce, who is the president of the American Association of Anesthesiologists in 1984, to Anesthesia Patient Safety Foundation. So, because, there's a wide publicity about this particular thing, and then everybody is concerned, every patient who has to undergo anesthesia is concerned. And am I going to come out satisfactorily? Am I going to be a cripple? So, Anesthesia Patient Safety Foundation is formed to make sure, what are the ideas? The mission of this foundation is to assure that no patient shall be harmed by the effects of anesthesia. That's the first mission. And to promote national and international exchange of information and ideas about the causes and prevention of anesthetic morbidity and mortality. With this mission, they started this foundation. And what are the first step that was taken? And if you look at the statement now in 2005, safety research and education, patient safety programs and campaigns, national and international exchange of information and ideas. In about 20 years, the motto remained the same. It did not change much because the focus is on that, and the development all over the world is taking place. Now, first they focused on equipment design, because we listed so many causes for equipment failure, and so they took up that, and then very stringent safety standards for anesthesia machines and monitors were introduced. You'll say ASA guidelines for this, and also you will have ASTM, testing of machines guidelines, which have come into force, and every machine that is produced have to go through and pass that. So not only that, the manufacturers were made to comply with all these standards that they have put up. This should be the thing. And checking protocols for performance of equipment made mandatory before use. I suppose all of you are doing it before you start your case every day. Am I right? All of you are doing it? Checking it satisfactorily? Okay, good. Continuous monitoring of equipment performance and warning. So not only that, you have to check it. They said the equipment itself should do a self-check and then give warnings if anything is not all right. So these are the stringent measures about the equipment that have been put, and then manufacturers were made to comply by these standards. And then came out to the minimum monitoring standards in 1988, What are these? This has been adopted by the Indian Society of Anesthesiologists in 1996. Okay, what are these? Presence of a qualified anesthetist all the time with the patient. Oxygen analyzer should be there to say that what you are delivering from the machine is oxygen, and this is the percentage that is coming out from the machine. ECG monitoring to say that cardiac activity is all right. Pulse oximetry to say that saturation is okay, the oxygen is being carried by the blood to the tissues. And non-invasive blood pressure monitoring to say that circulation is satisfactory. And of course, EtCO2 was introduced in 1992 to say that there is elimination of carbon dioxide from the body satisfactorily. So to make sure that the patient is being monitored and homeostasis being maintained satisfactorily. You understand one thing that is lacking in this, what is that is lacking? Temperature, okay. Anything else? You are giving anesthesia. All that we are talking about, we are not talking anything about how much anesthetic that you are giving. We are only talking about how the homeostasis is maintained, how you are preventing morbidity or mortality because of not maintaining the homeostasis satisfactorily. It has still not become mandatory to say that you will have to monitor the agent level, how much you are giving as a standard because of the cost that is involved. But at least all this should be done. Now, towards the patient education, they started with a newsletter which is sent to all the patients all over and then put up in the website as well to educate the patients on the way, what to expect during anesthesia for different types of surgery. So there's a lot of information that have been given to the patient beforehand. So if they want to know when they're going to go for a surgery, they can look up for that surgery and look at anesthesia, what type of anesthesia, what to expect pre-operatively, what to expect post-operatively. On those lines, you can also go and have a look at this website. This is the issue at volume number 20, that volume number 20, number 4, that's in 2005 or 2007, 1984. Yeah, they started in 84, and this is the 20th volume, 2005. Now, after complying with the minimum monitoring standards in our institutes, okay, I'm saying our institutes because I have worked in 2 different institutes, JIPMER as well as here. Deaths due to hypoxic gas mixture, unrecognized esophageal intubation, circuit disconnection and inadequate ventilation were not heard of. You are unfortunate not to have this kind of seeing this kind of complications, but if you have this kind of complication, then you have a catastrophe in your hand. It is not heard of for the past 20 years. I'm saying unrecognized esophageal intubation. I'm not saying you are not doing esophageal intubation. It happens, but it is recognized that it is not in the trachea, mainly by looking at the end-tidal carbon dioxide tracing that is there. And so, not heard of for the past 20 years. And death implicating anesthesia as a major cause has come down, mainly because the transparency and awareness of patient condition to the entire team. Everybody in the operation theater knows how is the patient because the monitor displays whatever is happening to the patient. So everybody there knows what is the patient's condition. It is not unknown. This is an article published in 2006, Safety in Anesthesia. And what did they say in that? Future of safety of anesthesia partially lies in technological advances in the countries that can afford them. Is that the right statement? That's a question I am just raising. In developed countries, estimates of avoidable anesthetic mortality vary from as low as 1 in 2 lakhs to 1 in 10,000. Australia probably provides the best results, best data, and I won't say the best data in the world because they started monitoring this quite way back from 1990 onwards, looking at this particular data. But even there, it is difficult to determine the true rate with a confidence, because it is dependent on self-reporting of the complications. And then what is the risk that should be acceptable? That is the question that they have put. What risk would be acceptable now? What risk is acceptable now under anesthesia? Talk something. Tell something. What is acceptable? 1 in 1,000? 10,000? 1 million? 2 million? 5 million? What is it? What do you think is acceptable? Yeah? Nil. Nil. Yeah, that's a good target to say that no death is acceptable under anesthesia. Due to anesthesia, yes, okay. It could be a lot of patient causes, a lot of surgical side, a lot of other things might be there, but because of anesthesia, there should not be a death. That's a good goal. Should we at this juncture talk about mortality? It's a big no, because she said the target we have to fix is nil. So we should not be talking on mortality to say anesthesia is safe. What we should be focusing on? It should be the reduction of morbidity that should determine the safety and not the mortality. What do we mean by morbidity under anesthesia? Just think on that. See, in 2007, Miller, who has written this 8 editions of anesthesia book, he wrote in 2007, it is premature and counterproductive to content ourselves with the fact that few patients experience intraoperative death due to solely to anesthetic mishap. We need to take ownership of substantial perioperative morbidity. That is what we should be focusing on to say that anesthesia is safe. Even if a patient develops thrombophlebitis of the vein after anesthesia, it is a morbidity. Okay, so I am just giving you an example of what you should be looking at as a morbidity that has been produced by anesthesia. Just one simple example. If you have a sore throat, it's a morbidity. Okay. Now, 2010, we had a Helsinki declaration on patient safety in anesthesiology. And that is by WHO. And what did they say? All institutions providing perioperative anesthesia care to patients should comply with minimum standards of monitoring as recommended. Okay, that's a minimum monitoring standard should be adhered to in all the institutions that care for patients under anesthesia. That is the first thing. Second thing is, all such institutions should have protocol and the necessary facilities for managing the following. What are these? Checking of the equipment and drugs, preoperative assessment and preparation, syringe labeling, difficulty or failed intubation, protocol for management of malignant hyperpyrexia, anaphylaxis, local anesthetic toxicity, massive hemorrhage, infection control, and post-operative care including pain relief. Are we having all these protocols? Yes, he says yes, accepting this management of malignant hyperpyrexia, I suppose you have all these protocols written and all of you are aware of the protocol that needs to be followed if any of this happens. That is why we call our department to be at the world standards of giving care. You go to some other institute, you may not have the protocols written up there. You may not have certain facilities for doing certain things. Why do we call our department to be at the world standards? Because we are 99% complying with the declarations of Helsinki on patient safety. Not only that, all institutions providing sedation to patients must comply with anesthesiology recognized sedation protocol for safe practice. Okay, all institutions should support WHO surgeries, safe surgery, save lives initiative and checklist. Are we doing this? Are we doing this? Where do you do that? Little loudly, eh? Before surgery, what do you do? What checklist? Pre-operative checklist. What is this safe surgery saves lives initiative? Yeah, okay, then before incision? You have a checklist. I just want to know, are you following that particular checklist? The checklist, which is one page, has been divided into 3 pages in your protocol, in your anesthesia record. So I just want to know whether you recognize this as part of that. That's what I want to know. And it is the 3 things. One is before the patient goes into theater, then before the incision is made, and before the patient leaves the theater, the checklist that needs to be followed. And that is what is labeled as safe surgery saves lives. And WHO has given that form. And all departments of anesthesia in Europe must be able to produce an annual report of measures taken and results obtained in improving patient safety locally. Then all institutions providing anesthesiology care to patient must collect required data and be able to produce annual report on patient morbidity and mortality. I suppose you are doing it now. And all institutions providing anesthesiology care to patients must contribute to the recognized national or other major audits of safe practice and critical reporting systems. I suppose we are not doing that. So these are the recommendations by the Helsinki and for safe anesthesia or safety in anesthesia. Now if you look at the 2020, if you look at the mission of the Patient Safety Foundation, what do you find is that preventing, detecting and mitigating clinical deterioration in patients in the perioperative period. They are not just talking about anesthesia, death under anesthesia, avoiding that. It is broadened out now to say that preventing, detecting and mitigating clinical deterioration in the perioperative period. Then safety in the outpatient operating room locations such as endoscopy, interventional radiology, etc. Then culture of safety, the importance of teamwork and promoting collegial personal interactions to support patient safety. That is what I want to focus on. Are you people tuned up to that level? Collegial personal interactions. Are you people talking between each other about the patients that you do, about the progress of those patients? On those lines. I know all of you are quite silent. Are you doing that? The case you do you discuss with your colleagues afterwards at any time to find out, to say and have an interaction? And one initiative that I appreciate that has happened now is that preoperative check, and it is put up in the WhatsApp to the other group to say that this is a patient I have seen, please follow it up during anesthesia. And that's a good initiative that has come in the department. And quite happy all of you are doing that now. Improving safety, as I said, just mortality study is not really reflective of the status. Analysis of the morbidity is more reflective of the safety levels. Auditing at regular intervals is useful for correcting the closed environment. And policy making, you need incident reporting database if you want to make a policy. But auditing at regular intervals is useful for correcting a closed environment. So, in 2002, we created one database when I was in JIPMA. Dr. Shanmugam knows about it. It's a computerized database that you report your cases. And we also kept a Dropbox in which you can write and drop the paper into that. Reporting forms are kept in the theater so that if anything is there, you can just write and drop it into that. And active solicitation of information by one person by interacting with the people who have done cases. That is a method used for collecting the information. And what is the incentive? Incentive is anonymity. You don't have to disclose your name or anything. It is anonymous reporting, and then there is a promise that no punitive action based on the report will be taken. Okay, no punitive action will be taken based on the report that have been given to this database, which means you give, if you have done a mistake, you can be rest that you report it, and then so that some correction is done, you will not be punished. That is what it is. Incident. What is an incident? Any deviation from the normal process at any time is an incident. So, and we classified these incidents into no harm, near miss, adverse, and death. This is how it was classified. What is a no harm? What is a near miss? We'll go into that details later. And then you are also asked to report about the place, time, description, and management of the case. Okay, this is how the reporting is done. And the root cause analysis is done using coding of the incidents. They were coded and then divided so that when you are looking at the incidents and you do not know, you do not trace it back to what has been reported. So people who analyzed the root cause analysis did not know what, when, where it happened, all those things they did not know. They only knew, and it has been classified under the few headings. What are these headings? It has been classified under inadequate precautions, inadequate preoperative assessment, lack of vigilance, and checklist not followed, and lack of communication, fatigue, haste, lack of knowledge, lack of experience, and lack of skills. Okay, these three were added specifically to identify the trainees, and these all other things is common for all. So what did we find? In the 2 years we had a total anesthetics of 17,900 anesthetics, and of which 156 incidents were reported. There were 45 no harm, 64 near misses, and 41 adverse, and 6 deaths. This is what is the report. We know it is not a complete report because it is sporadic in reporting and it is dependent on a lot of factors, but it is quite a good representative of what we had. So what did we find? The incidents, when you classify them, we found that elective cases in ASA 1 and 2 patients had the maximum incidents happening. Elective cases during the daytime, maximum number of incidents in ASA 1 and 2 patients. And that is what is very glaring when you look at this particular table. Why is that so? If you look at the thing that ASA 1 and 2, there are 38 near misses and 20 in ASA 2, 23 and 11, the total of 92 incidents at the time. What are the monitors used? Patient monitoring, pulse oximeter, ECG, NIBP, and end-tidal carbon dioxide. It's all 92 had that, and 48 of them had EtCO2 monitoring. And machine monitoring is oxygen analyzer, nitrous oxide, and the agent monitoring in 28. In spite of this, these are the patients who had all these monitors on. And how were these incidents picked up? What is the best monitor that picked up all these incidents? Any guesses? Yeah? Loudly, loudly. EtCO2. Anybody else? Any other guesses? Don't hesitate, man. Talk something. Nobody is going to blame you. I have told, no? There will be no punitive action for reporting. No punitive action will be taken for telling something. What else? Yeah. She has heard my lecture before, I think. By a senior anesthesiologist who goes from one theater to another to supervise when juniors are doing cases. all these 92 incidents were picked up by the persons who go from place to place when cases are going on, not by the machines. And what are these incidents? Inadequate precautions, 19. Then inadequate preoperative assessment, 16. Then lack of vigilance, 37. And checklist not followed, 12. Lack of communication, 12. Lack of skill is 11%. So all this, no monitor is going to pick up all this. Inadequate precautions, inadequate pre-op assessment, lack of vigilance. All this is not going to be picked up by the monitors that you are looking at. So safety in anesthesia does not depend on the machine and the monitors that you use. That's what I just want to imply on you. You can have best monitors that is there in the world for monitoring the patient, but the brain behind that which looks at that monitor and interprets the values that are there, that is much more important than the values that are displayed there on the monitor itself. If you don't interpret those values, then there is no use of having those monitors. So they do not, yes, they contribute, but the safety does not depend on them. Safety depends on the person who is there physically present. That is why one of the minimum monitoring standards is a qualified anesthesiologist to be present all the time. And that person should also be knowledgeable to interpret all these findings. If that is not there, again, that is useless. So, with that, I just move on to the non-technical skills of anesthesiologist. Non-technical skills are cognitive and social skills that complement technical skills to achieve safe and efficient performance. This is how the non-technical skill is defined. What is this non-technical skill? Why focus on non-technical skills on the OR? Good non-technical skill can lead to positive outcome for the patient. Okay, adverse events in the operation theatre are primarily caused by failures in perception, judgment, communication, and teamwork. That is what it is. Okay, I'll just go to an example. This is a trend monitoring that has been picked up on one case. This one, when I just walked in at 9:08, that's the time I just walked into that theatre. And this is the patient, a 2-year-old child who is going for a pull-through, abdominoperineal pull-through, is being positioned after anesthesia in a lithotomy position. When I went and checked up and put a hand on my pulse, and I found the pulse is very thready. Or sometimes I did not feel the pulse. So I told the anesthesiologist this, start cardiac massage. And then I moved over to pick up the adrenaline, load that adrenaline, pick up and come. By the time I did that and I came back, cardiac massage has not been started. Has not been started because the anesthesiologist who was attending on to that looked at the monitor and said, why the hell this man is telling me to start a cardiac massage when I have the heart rate of 144, saturation of 100, and here, and ETCO2 of 38. Why the hell he is asking me to start cardiac massage? He did not start. Then I shouted from that place, start the cardiac massage. Okay, and without knowing anything, yes, they started the cardiac massage, and they did not recognize that NIBP has not recorded the blood pressure. At that particular time when I said the NIBP has not recorded the blood pressure, and which is supposed to be doing it every 3 minutes at that time of induction, and they did not recognize that particular thing. And they started with the cardiac massage. By the time I came back, and you find in that next 1 minute, you find that ETCO2 has started dropping down. It has come down to about 10 or something in about next 2 minutes, and the heart rate has dropped down to 50, and the saturation also showed a drop. And the NIBP, there is no recording there. So we started with the cardiac massage. We gave the adrenaline, went through the protocol, and you find in about 5 minutes time, we got back the spontaneous cardiac rhythm. I mean, there was no stoppage, but it came back to a satisfactory level. Then you find the ETCO2 started going up, and here even for cutting off, the agent was cut off at that particular time. But to cut off the nitrous oxide and go into 100% oxygen took some time for them to realize, no, I have to do this. I have to cut off the nitrous and then give 100% oxygen because I am trying to resuscitate the patient. Okay, so it took some time, and in about next 3 minutes we restarted we established a satisfactory circulation. I won't say restarted the heart because heart was beating all the time. We re-established the circulation which is satisfactory, and then ETC started recording some EtCO2 which went on, and when the circulation was satisfactory, the EtCO2 went up to 50 because it was washing out whatever was not removed at that particular time. And then we had a satisfactory recordable blood pressure in about 15 minutes, which is sustainable recordable blood pressure. And and the EtCO2 stabilized around 38, and the heart rate stabilized around 130, and the SpO2 was 100%. And we have to restart with the nitrous oxide at that particular time because the child started opening the eyes to command. Okay, then we have re-established all these things. We waited for another about 15 minutes and then reverse the patient because we have to make sure that neurologically the child is satisfactory, the child is good. So we recovered the child and then sent to the ward, monitored for 2 days for the behavior and assessment, and everything was satisfactory. So we took up the case again after 2 days and went through the procedure satisfactorily. Okay, so that is what it is. What are the factors that contributed to this? One is the perception. Second thing is assertiveness. If I had not shouted, if I had not started the massage at that particular time to continue the circulation satisfactorily, then things would have been totally different. And communication and teamwork. See, these are the factors which contributed to the satisfactory outcome in this particular child. And these are the things that are not being taught. Nobody teaches you all this. So these are the non-technical skills that you will have to attain. Now you just take this Mrs. Elaine Bromley's case. I don't know how many of you are aware of this. Possibly Hemant knows and he knows. All of you are aware of this particular case, which has been publicized in the net. Now, March 29, 2005. Elective surgery, septoplasty and functional endoscopic sinus surgery. Then anesthetist and assistant present a thorough preoperative checkup. There was slight restriction in her neck movement, but nothing to suggest a problem with the airway management. That is what is the preoperative assessment by the anesthesiologist. And then no pre-oxygenation done. 8:35, GA was given with propofol. LMA insertion was done. There's no satisfactory fit of LMA. And then 8:37, sinus, SpO2 was 75. Readjustment of LMA, re-intubation, repositioning of the LMA, all that were done. 8:39, SpO2 was 40%. Then they started attempting to intubate the patient. They thought LMA is not going, let me take it out and put a tube so that the case can continue. That is and by the time it was 4 minutes after the induction of anesthesia, saturation was 40%. Now 8:41 to 8:43, what happened? Joined by the ENT surgeon, other anesthetist, and at least 3 nurses of the team of consultants. All of them were available in the theater. Bradycardia and SpO2 40. One nurse went to the phone, CCU, to phone the CCU, as she was shocked by the position, and she returned back and announced a bed is ready, available in the intensive care. That's what she told the surgeons there and anesthetist. Then the consultant looked up and said, as though, what's wrong with you? You are overreacting. She went back to the phone and canceled the bed. That's what happened at that time. She just went and called up the ICU and said, and the person looked up and said, what the hell you are doing? And then she went back and canceled that bed. And another asked her colleague to fetch the tracheostomy kit, and then on her return she announced the consultant that tracheostomy set is available, but she was ignored. 8:45 with hindsight, now cannot intubate, cannot ventilate. Consultant continued to attempt intubation. 3 consultants, 1 ENT surgeon, 2 anesthesiologists continued to attempt an intubation. By 9 o'clock, eventually got some air and 90% oxygenation achieved. after 20 minutes at 40% saturation. At 9:10, they decided to wake her up and then transfer to the recovery. This is what happened. And she was later shifted to an advanced center without any protection of the airway for life support on 5th of April, following discussion with the family and assessment by the senior consultants. A decision was made to withdraw life support treatment, and she died on 11th of April 2005, 13 days after the anesthetic. This is in 2005. Okay. Now, her husband Martin is a pilot. He was astonished. Her anesthetist had been a consultant for 16 years. The ENT surgeon had 30 years under the belt. The theater is well equipped and there is no emergencies elsewhere. There was a dream, this is the dream scenario for safety. A senior surgical team working undisturbed in the state-of-the-art surroundings. That's what it is. What the hell is going on for the patient to suffer damage like this? Why should it happen when everything is like this? He insisted on inquiry, promising that he will not claim compensation. He said, I will not claim compensation, but I want an inquiry to be done to establish the fact that has happened, what happened, how it happened, and so that people know. And so an inquiry was instituted. As promised, he did not claim compensation, but as a pilot by profession, he wanted correction to be done. He wanted medical profession to respond. Report was made available to the public in the net. He cried out in the media to bring about a change. All this he did. He didn't ask for the compensation, but all this, he did all this. That's why it is available freely for everyone to have a look at it and go through that. Okay. Now, what does that report say? Too much time was taken trying to intubate the trachea rather than concentrating on ensuring oxygen administration. Okay, lack of decision making. Not all clinicians were aware that there was a problem with ventilating this lady. What is that? Lack of communication. The clinicians became oblivious of passing time. So almost 20 minutes has passed trying to intubate. They're not aware that so much time has passed, and it's a lack of situation awareness. And surgical airway access by either tracheostomy or cricothoracotomy should have been considered and carried out, and it is lack of leadership. All these are non-technical skills. Okay, so this is what finally contributed to the worst outcome. Now, look back, Tenerife 1977. Two Boeing 747 crashed into each other on the runway. 583 people died. Not all flying, not all taking off on the runway. Two Boeing 747s crashed into each other and 583 people died. Causes? Lack of conflict resolution, assertiveness, communication, situation awareness, and stress. All non-technical skills. Understand? 583 people died. I am just leaving it for you to read. Why do doctors kill more patients than pilots? Because they don't die with the patients. You don't die when a patient dies, but a pilot dies when aircraft crashes. So the airline industry is shocked to realize that well-trained and technically proficient crew could crash airworthy aircraft because failure of human interaction, communication, areas in which neither training nor formal evaluation is required. And research showed clearly that more than 70% of airline accidents involve some degree of human error. More surprising was that most of these errors stemmed from failures in communication, teamwork, decision making rather than technical shortcomings. That's what it is. This is the findings. Okay. So what they researched and what they did was they instituted a program called Pilots Non-Technical Skills. The NOTEX. It's a taxonomy and of behavior rating system for pilots non-technical skills developed in Europe. This is the person, Flynn, and she worked along with them in the industry and then came out with a taxonomy and a program under which they can be trained. So they had a program, all of them have to go through a standard operating procedure and get trained in the simulator, and at every 3 months they have to undergo this, and they have to establish, yes, they have a proper kind of non-technical skill and communication skill with each other to manage situations that arise out of just suddenly like that. Again, you had a crew resource management, optimum use of all available resource equipments and procedures and people to promote safety and enhance the efficiency of the flights. That's what it is. So, and she later went on to talk to analyze research about anesthetist non-technical skills, and it was short called as ANS, anesthetist non-technical skills. She outlined the taxonomy for that particular system, and what did they have? 4 components: decision making, situation awareness, team working, and task management. And then each one of them had elements in them, like if you take the task management, planning and preparing, prioritizing, providing and maintaining standards, identifying, utilizing resources. These are the elements that go into. So each one of them had elements, and these are the categories and these are the elements, and this is the behavior, check equipments, prepare drugs, etc., about the behavior of the people who are working. So this is the taxonomy that has been put forward, and then a rating scale. These are the elements in that particular for each one of these categories, and she went on to give a rating scale from 1 to 4, how to rate the non-technical skills of anesthesiologist. And good is a performance is consistently high standard, enhancing patient safety. It could be used as a positive example for others that got the maximum marks, and then skill could not be observed in the performance endangered or potentially endangered patient safety, and serious remedy is required. That is put as poor. So you had the other two in between, and this is how the taxonomy and the rating scale has been produced, and to look at how to go about rating people who are getting into anesthesia to see how good they are in non-technical skills, because they were confident that technical skill all will be attained in a period of 3 years' time, but these things are not possible. So this taxonomy has been tried in many hospitals. Every journal in 2008 carried an editorial on patient safety. Every journal carried an editorial, and WHO recognized the need for ensure safety for patients and come up with the Safe Surgery Saves Lives in 2008. And emphasis is on structure of the system. Now, if you look at it, human factors. What are human factors? Human factors are all things that make us different from logical, completely predictable machines. Each one of us different. Each one of us think differently. Each one of us focus differently. So this is what makes us human, and how we think, how we relate to the other people, equipment, and our environment, that matters. It's about how we perform in our roles and how we can optimize the performance to improve patient safety and efficacy. That is what is the focus. It is, in simple terms, it is the things that affect our personal performance. Finally, with all this, finally it comes down to who you are, how you think, how you perform, how you correlate, how you interact with the people around you, and that is what finally enhances the patient safety. And these are human factors. There are a lot of other human factors that we have listed on the training period, which can lead on to morbidity, but these are most important even as you grow up in your specialty, to concentrate on all this, because these are the things make what you are. These are the things make you what you are. And if you want to be a good anesthesiologist, you have to focus on these things along with all the other technical skills and other things. Your communication to others, interaction with others, openly talking about the events, and educating yourself and educating others is the most important thing. And that is what we are trying to promote by telling you to put up e-portfolio, which can be discussed, which can be organized, and which can be commented upon for the improvement of your own self. Okay, to conclude, this is not an invention. Okay, what we already knew but could not quantify, this is a rediscovery. This is not specific to anesthesia, but pertains to all specialties. No text for improving, the no tech is non-technical skills for improving patient safety in clinical practice. It is time we acted on developing, assessing, and refining these parameters. Thank you.